A very good evening to one and all. Thank you so much, and it's really privilege for us today to have this wonderful MedTech Insight podcast, season 2. Once again, very good evening to everyone. Thank you so much. It's a really privilege for us to have this wonderful event, which is a MedTech Insight season 2 in collaborations with JV EdTech and Power of Knowing Forum, a collaborative healthcare podcast series. Welcome once again. Beyond procedures, ethic, experience, and patient centric outcome in surgery. Thank you once again for joining us. Yes, wonderful. Now it's my privilege to introduce Dr. Charudatta Chaudhari, who is a renowned, experienced surgeon and consultant. Since 26 years of experience, he has been he's been serving with us with the different knowledge and different segment. He is MS DNB plastic surgery with a higher accolades. He has been fellow of Chang Gung Memorial Hospital, Taiwan in reconstructive microsurgery. He is also fellow of the Ivo Pitugai Institute of Anesthetic Surgery, Brazil in cosmetic surgery for face and body. He has number of research and publications. He has more than, I must say, more than 20 publications, which are there in front of me at this moment. He has been working with the various expertise uh, since 2000, and he has worked with an honorary consultant plastic surgeon at Bombay Hospital. He has even associate honorary consultant plastic and reconstructive microvascular surgeon at the Bombay Hospital, Ambani Hospital, Prince Ali Khan Hospital, as well as Dr. N.M. Kavrana. And also, he has been part of the major association in his life. I must say that, he's also a certification and professional membership with the Plastic Surgeon of India and World Society of Reconstructive Microsurgery. We welcome you, Dr. Charudatta Chaudhari. Thank you so much.
Thank you, Jyoti. Thank you for your kind introduction.
Yes, and I think today it's going to be really amazing session because when you say beyond procedure and ethics, experience, patient centric in modern surgery, what really matters a lot. And believe me, probably this era of Gen Z, you have seen many other modalities or many other outcomes too. But looking at the surgical procedural aspect, let us dive down to the first question. Like, after more than working for 26 years in surgical practice, how has your personal definition of successful surgery evolved over time? Over to you.
So, when I was a student, I used to see surgeries happening, and I would have a fixed outcome in my mind, and then that outcome would be without absolutely any complications, and patient should sail through everything, and the surgery should be the only uh, happening or untoward happening in his progress in front of us. Rest, minimal dressings, minimal pain. That is what would be in my mind. And when I started realizing that not having complication is absolutely not possible. It is not practical. So certain complications are inbuilt, and they actually stem for the patient's biology, because patients only appear to us once their health has deteriorated, and then certain things are almost are likely to happen. So now what happens, every surgeon has now two definitions in his mind of success. Once is, as a surgeon, what he feels is success, and what the patient sees it as success, you know so patient will see surgery as a success when all the problems that he has come or he has approached the surgeon with, all those problems are solved, and there are no new problems which have occurred. That is when the patient feels that okay, this surgery is successful. Now, there are certain reconstructive procedures where actually surgeon will feel that he has achieved almost all the goals and maybe a few unavoidable complications have happened. uh, Counseling the patient is the most important thing, where the surgeon's definition of success and patient's definition of success both will match. If there is been correct counseling, then both these successes should match. That will tell us that correct counseling has happened. And now my definition lies that, this the surgery should be called as successful when everything that I could have changed in patient's life, has been achieved by my surgery. That is the successful surgery from my point of view. Usually, patients are not very harsh on us, and they are very lenient, and their definition of success is quite lenient.
Absolutely. I must say that when you had mentioned that the trust part, which plays a major role in any kind of a counseling setup. However, I would like to know what first drew you towards a patient-centric philosophy, and how did a real-world clinical experience shape that mindset?
Uh, so, uh, I kept on observing that most of the times patients are unhappy for certain transactional reasons rather than the procedural reasons. You know, Transactional reasons in the sense that they are unhappy with the number of times charging has happened, or the amount of charging that is there, which actually is not going to matter to them in long run. What is going to matter to them is how the procedure has been performed and how uh, the the impact of the procedure is on their life, rather than these things. So these things then told me that uh, patients are unable to see into my mind, what I am going through while taking decisions, and what I am afraid of, how mm, what are the probabilities that this patient could have gone through a complication which is extremely major, and how I stood between that complication, happening to this patient. So then I started realizing that this happens only when I open the window of my mind and allow the patient to peek into, you know, to be frank with him, let him understand that, okay, see, I am worried because your health is this. And then when health has come to this stage, these are things that are going to happen to most of the patients. And because I am worried about this complication, which will impact your life in such a way that I don't want to choose this surgery, and I would rather, advise you to go for the other type of surgery. When this started taking place, when I allowed the patient to enter into my mind, then I realized that the faith that the patient has in me is also increasing. And as the faith increases, I realize that the stress that patient is under also reduces. Once the patient stress reduces, I have seen that obviously the outcomes have started getting better and better. So this is how I realized that I have to be as frank with the patient as the patient is being frank with me. So this changed my attitude towards being more patient centered.
Yeah, very well said. When you talk about the different approaches towards the patient centric, or we have, end to end, selections of the different processes or the different philosophy. When you consider even primary hospital, secondary hospital, even the tertiary hospital, but the mindset and the growth mindset, which is really important when it comes to understanding the patient, helping the patients, and 101% sure when the doctor comes with you on a different cases, and that specifically with the plastic and the reconstructive surgery, that really made a huge difference, I must say. So thank you so much. Moving to the ethical in the modern surgical practice, which plays a major role once again. So, with an increasing technological sophistication and patient expectations, Where do you believe ethical boundaries must be clearly drawn in surgery today?
Um, so there are, I think, various aspects about this, because ethics comes in, advertising. Ethics comes in surgeon-patient interactions, and ethics also will come in charging also. So now let us take advertisement. So now there are so many ways a surgeon can advertise, and I feel it is a borderline ethical problem. So as a surgeon, I refrain from advertising from any point of view, any whichever way. But it may not be practical for most of the people. But I would say that if everybody decides to, let go of advertising, then this. Uh, there is so much of stress also of advertising, keeping
Okay,
track of whether the person is utilizing funds properly, whether those funds are, you know uh, are of really of use to the person or no. So if we let go of this part, then maybe our life will also becomes better. That is what I have felt. Now, the
okay,
second aspect of ethics is in patient and surgeon interaction. So, what happens now? A lot of information is available to patients, and then these patients will come to you and will try to persuade you to give them the treatment that they want or they feel is the best for them. Now, after multiple sessions and enough counseling, if you are unable to let the patient understand that what is best for them, and patient's understanding of what is best for them and your understanding for what is best for the patient does not align, then I think it is ethically not right to continue treating such patients. And then the referral to a colleague or other person who is working in the similar problem area becomes mandatory. And then third ethics problem comes in charging. So now there are certain hospitals or certain way where post surgery or post procedure follow ups are charged already. The charges are included already in the procedure. Now it is not ethical to already charge for the services which are not been rendered, you know though it might, people might find that it is extremely minor point, but I feel that ethically it is wrong. Yes, what you can do, you can waive off the charges of your first consultation, but including those charges in your procedural charges is not very, it doesn't fit into the ethics.
I think you really hit absolutely bang on. And I must say that uh, when it comes to ethical dilemma in specific with the healthcare sector, uh, it is a two-way process. What patient pursue it and what healthcare professional pursue it. And I must add on to it that what would be the private setup and the procurement part when it comes to the charges, another part that comes into it. So I must say that over a period of time, you have come across with the different experiences and different scenarios, and which can really shape you as a person, and that really help you to build up your integrity and as part of a trust with your customer and with your patient. I must say that customer for the hospitals. Anyway, so fair enough. The fourth question: how do you manage patient expectation, especially in aesthetic procedures, without compromising clinical integrity or ethical responsibility?
That is a very tough question, because nowadays we are starting to find aesthetic patients to be very demanding. Uh, and they come well prepared, which actually is good for us, because we want to impart as much knowledge to them so that they can make good educated guess decisions towards their betterment. Okay. So if they have read well, then counseling becomes better. So I think proper counseling is the way forward to to get over this without compromising on clinical integrity, and all the complications need to be told to the patients. Don't we cannot just shy away from telling them that there is a minimal possibility that patient may die on table. So how to bring this up without alarming the patient? You can just say that, okay, uh, we had a problem with certain patient, or certain other hospital had a problem where the patient died on table, and then the next of the kin was not available. So, would you like to represent the next of the kin in case you are unable to take decisions? You know, so this can be brought up in such a way without alarming the patient, but you have to tell each and everything to the patient. You can otherwise say in such a way that, okay, there have been deaths, in aesthetic surgeries, but the incidence is extremely low and falling. Continuously it is falling because we are because of technological advances in anesthesia. We know and we are able to pick up the things when they start going wrong or even before they start going wrong. You know, so in such ways you can always talk to them, and when you talk to them about all the complications, you find that patients' expectations fall. What they expect out of the procedure, that also falls. And then now you have a very uh, patient who will follow all your orders because he knows what is at stake. He knows, and it is that surgeon is taking all the care to keep him from harm. That is which is the most important thing. And then when he has a positive result, then he is extremely happy. Nothing negative has happened, or if even if something negative has happened, that is time bound. It is going to be corrected in certain weeks time or maybe a month's time, and he is going to have a lasting pleasing result. That is what then patient remembers you for, and he is always he becomes a friend for it.
I must agree. I must agree. However, you have mentioned that the patient who has the knowledge and patient who has an idea about his own situations or own conditions, or he might have gone through the several other diagnostic evaluation criteria. But when it comes to the ethical responsibility or the clinical integrity, it is predominantly very important. And it can really help us to uh, create that I must say that background or the area of
Mm.
expertise where patient can
Yes,
rely on us, and we
correct.
can help the patients in a better way and the better shape as well. So moving on to the fifth question, in your experience, how has the concept of informed consent evolved from a legal formality to a meaningful ethical dialogue? Now, in
Mm.
this, I would request you to narrate few examples. I'm sure you must have had from the Bombay Hospital, Ambani Hospital, Prince Ali Khan, KDA, and Napul Navi, Mumbai, where you're working as a senior most consultant and surgeon. Over to you, doctor. Thank you.
So, see, as I told you, that informed consent is it is a starting of a dialogue between patient and the surgeon. You know, so when you are explaining to them, you can understand how they behave with each complication. When you explain the complication, how they are going to behave and how they are going to react to it. That tells us how important it is for the patient not to have this complication. And if something like that comes forward, that okay, uh, delay in healing. If they say that, oh, no, no, I can't have 6 weeks of healing because I am planning for a function, or I want to appear for a function in 3 weeks' time, then this is the time. Then you tell them that, okay, then it may not be possible to have your surgery now, and it is possible to delay. It is preferable to delay. Or then we just tell them that okay, there is 2% possibility that this may get hyperpigmented. The scar revision, after scar revision, this is likely to get hyperpigmented, but maybe just 2 or 3%. They said no, 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 this won't do. Then we tell them that okay, that if you don't want to do this way, then we would rather that you go through certain preparation of your skin or changes in diet so that you come prepared, your inflammation in the body is reduced, and when we do the scar revision, the likelihood of having hyperpigmentation is extremely low. So when we start talking to the patient, we realize what is important to them and what is not important to them, and how afraid they are. Whether they are afraid of anesthesia, whether they are afraid of. There are people who are afraid of local anesthesia and then they prefer general anesthesia. There are people who are afraid of general anesthesia and then they want local anesthesia. So this is extremely. So we get all sorts of people. So after talking to one patient, I gave them all the informed consent. This was a cancer reconstruction patient, and then this patient, then he told me, "Doctor, I'm a painter." I said, "Very nice. So show me your painting." So I saw his painting. I said, "Such a good work." So I said, "Must be taking hours and hours, to do such works." So I said, "Even we consider, ourselves as an artist, but we are not as good as you are." Then that painter thought about for a while. He said, "No, no, no, doctor. I think you are better than us." So I said, "How come? We never, create any masterpieces which can be hung on the wall." They said, "Doctor, for each masterpiece that is hung on the wall, there are at least 9 to 15 canvases that I have thrown away. You know, a plastic surgeon cannot throw away a single canvas. Each canvas has to be a masterpiece."
Wow.
Mm.
So beautiful. I must say that when we started understanding your journey, and such a beautiful over a time, a flawless, and I must say that you worked with such a beautiful process of the patient dignity, of course helping them, creating that trust, and even with the technical excellence, which is an essential part of your learning and development, and of course patient centricity, what we have encountered with your experience, that has really given you the best of the ideas. The segmentation part, when it comes to the ethical modern ethics in the modern practice, which has really have a clinical necessity as a patient benefit and the proportional risk over period of what you discuss at this moment with us when it comes to the patient expectations, particularly in aesthetic surgery, which helps them to preserve their own integrity, and it is a major responsibility which required the educationals and the transparency. And not only that, but even when we know what is best for the patient, and when we know what can be really help the patients to develop themselves with the best outcome. So with this, when with your perspective as well, the informed consent might be seems to be a very simple documentation process in hospital, but it cannot go without having counseling and helping the patients to empower them, and even to strengthen their trust for not only to help them, but even rather than simplifying the fulfilling the other obligations too. Moving down to the segment of 3, where we have a beyond aesthetics, restoring functions, dignity, and quality of life. Dr. Charudatta, can you share a case where restoring function or dignity took precedence over achieving a visually perfect outcome?
So actually, this is a very common occurrence in reconstructive surgery, which is post-cancer reconstruction. So there are certain patients who come to us in early stages where we can think about function and cosmesis together. But there are certain patients who come to us at a very late stage, where the mass is fungating, and the end, the days, when actually patients should be with their near and dear, or certain relatives, even they cannot come near the patient because of the foul smell, or because of the ugly looking growth on the cheek, all these things. So it becomes very important that we give that patient dignity and towards his last days, rather than trying to achieve cosmesis, So when we do such surgeries, we don't really have the focus of cosmesis in mind. So I remember one mm, a very simple fellow, very devout fellow. He used to sell agarbatti, and then he came to us very late with exophytic growth, sitting here. And then I told him, I said, though the free flap is the best for him, because he was a very thin guy with blood pressure also remaining low. So in such cases, when we do microvascular transfer, if the hypotension becomes more severe, we are in the process of we can lose the flap. So I said, best for you is to do a pectoralis major flap, which is a little older way of reconstruction. And when we did such a flap, and he recovered very rapidly. And for surprise to all the cancer surgeons, he was alive for a year. And he said he used to tell me that I want to go with my Ganpati. And after he passed away, the relatives told me that he died on the Ananta Chaturdashi. He was sitting in front of the Ganpati, and he just in front of the Ganpati only died. So that is how sometimes we don't want to go full scale for such patients. We want to give them good time. And I feel sometimes giving chemotherapy, etc., is also sometimes doesn't add to their quality of life. It may increase quantity of life for a while, but still compromising the quality of life. So somewhere in such cases we have to understand, and even relatives have to understand, rather than even doctors, relatives have to understand when they are harming the patient and when they are helping the patient. It's a very thin line, and as surgeons, we just have to guide them through it.
Yeah, absolutely. I
Mm.
mean, very well said. And that really story, they give me a goosebumps because we know
Mm.
it's really, really important that how patient perceive it. So in reconstructive surgery, especially post-trauma or a cancer, there are many instances where the functional restoration is more important, and, we have to have a look for the psychological recovery as well. So this incident and example which actually shows the independence, confidence, and the social reintegration through the modest
Mm.
surgical improvement can really help better. Thank you so much, doctor, for sharing that example. Now, moving on to what role do empathy and communication play in complex reconstructive cases involving trauma, burns, cancer survivors, or any post-operative situations?
Uh, so whenever it comes to any complex reconstruction, the problem is that the mm, cosmesis and the function, they are most of the times at odds. So when you want to give good cosmesis, then the function is a problem. When you want to give good function, then the cosmesis is a problem. This is typically occurs at the when we want to reconstruct the commissure. When we want to give a normal commissure, uh, which is at the same level. When we try to give function, then patient feels that the mouth does not open properly. So they feel that it is inadequate. And if we give them adequate mouth opening, for that we have to move the commissure towards lateral side. When we do that, they feel no, no, it doesn't look good. So people who have got the correct commissure want it to be widened, and people who have got wide commissure, they want it to be made smaller. So this is exactly what happens in our life also. We always see that grass is greener on the other side. We always go after what is not with us, and that is how we most of the times while away our life, running after things which are not with us. And when we actually get them, we realize that this is not for me. you know so I think education and education, patients have to come to a surgeon or a hospital as they approach a temple. Faith is very important. If after multiple counseling, patient does not develop faith in the surgeon, then sometimes it is advisable that another surgeon takes over the patient's treatment and tries to develop faith. You know, and there are still certain patients who are paranoid, and they don't do well. We have seen that paranoid patients don't do well. I think Bollywood is quite responsible for this situation. So what Bollywood has done is that it has developed a distance between patient and doctors. They have portrayed doctors in such a way as if doctors are going to always trying to earn money out of patients. Now you have to understand, in this era, there are so many avenues of earning money that we don't have to have this uh, operating on patients and then taking money from them. That is, I think, the very uh, very slow way of earning. There are very other fast ways of earning. And we being quite intelligent people, we are actually earning that way. So they have to understand that we are not here to get money from them. We are in this profession to get satisfaction. The satisfaction of helping a fellow human being, that does not come with the other ways of earning. You know, Bollywood has to rectify their own mistake. Patients have to understand that we can, though we a surgeon can earn money in multiple ways, patients can only get better only with a doctor only. Whether it be a western medicine doctor, homeopathy doctor, allopathy doctor, ayurvedic doctor, or Unani doctor, it has to be a doctor. It can't be anybody else.
Absolutely.
Mm.
Absolutely, I echo with that. And in the beginning of our discussion, Dr. Charudatta, I have mentioned that when we talk about the current generation, probably 30 to 40 years, where you might have seen many patients who would like to go for aesthetics, who would
Mhm.
like to change their looks, their features, the way they are trying to show different ways and means, right? But I strongly believe that the empathy and communication are central, not supplementary to our surgical care. In
Mhm.
such cases, obviously, and the patient who carry a physical scar outside deep emotional trauma. Now, talking about the deep emotional trauma, I would like you to give me, and definitely a one case study in case if you have with a burn specific to talk about with a female in case. Thank you.
So today only actually one lady followed up with me after 13 years. 13 years ago, she had gone to see off her in-laws, and she helped her in-laws to get into the train, and then the train started, and while getting off from the train, then she had amputation of her limb, lower limb, and we tried our best, to manage it to be below knee, but somehow the mangling was so much that we had to do an above knee. Above knee is extremely incapacitated. It's not a very good way. And that also, there was a lot of skin which was lost. So she was with us for very long time. We put skin grafts and then created the stump in such a way that she does not have any further problems, because when the above knee amputation process is worn, the amount of weight that is put on the processes is quite large. And with the piston like action of the prosthesis, of the limb in the prosthesis, a lot of ulceration can happen. So today she had come after 13 years and she showed me her other limb. So she had problem with the other limb, and I was so relieved, you know, that she does not have problem with the reconstructed limb. She has problem with the other limb, and it was a very small problem. I said, now you're aging. Certain chronic lifestyle diseases are catching up with you, and just you have to take care of your diet. And this is a small problem. It's just it will go away. You know.
Oh, yeah. So I'm sure this reminds me one of the incident where in when I was in Conotec and I had our clinic with the vascular and endovascular surgery. Okay, so we always had this beautiful collaborations with the general surgeon, plastic surgeon, vascular endovascular surgeon. There are many patients who comes with a different I must say, the different issues and which can really impair their health system. And it gives a sense of awareness, or the sense of responsibility or achievement, I must say, that when you see your patient has been really recovering well. Okay, and what you meant, like our clinic was meant for a limb salvation center, and I'm really grateful to Dr. Sanjay Desai in the experiences when we used to salvage the limb. Okay, that was something really very well. I echo that example. So, doctor, now we are moving on the experience, mentorship, and the surgical leadership. According to you, what ethical or professional challenges do young surgeons face today that were less prominent earlier in your career?
So what I have noticed is that nowadays the younger generation wants to start their clinical practice early. So and when they start it early, they usually don't get as many patients. Previously, what we used to do, we used to be associated with a senior surgeon, and then the hands-on experience would start. Because the senior surgeon would have his patients, and then we would be helping that person with his patients, taking care of the patients, and slowly we would see how the patient surgeon interaction is, and then we will learn it on the go. But when a young surgeon goes into clinical practice directly, then they take help of third party to get the patients, and this actually causes a lot of vitiated atmosphere in the doctor patient relationship. No third person should enter doctor patient relationship, and we should see mm, as a profession that nobody should be allowed to enter as a mediator. It should not happen, because once it happens, then these third party people, they because they haven't taken Hippocratic oath. Hippocratic oath is we have taken. So we have this onus on us not to harm the patient. So that onus is not on the third party patient. When you get such a person inside in this such sacred or sacrosanct relationship, things are not going to do well. If government is listening to this, government should take proactive action and should remove all the third party from there. Nobody should come in between. And then when they start young surgeons, when they start surgery, then there is also pressure on them to perform rapid surgeries, where they want to be seen as a fast surgeon, a surgeon who can do procedure within 10 minutes or within 30 minutes, where other people are taking 15 minutes or maybe 45 minutes. So they have to understand that speed in surgery should never be primary. You should always think about precision and uh, being perfect. Though obviously being perfect is just a notion, and you have to always know that being good is the best thing for the patient, because when you try to achieve perfection, sometimes patient gets harmed. So that is a different philosophy altogether. But every time you have to understand that each step should be performed with utmost care. And if you to keep doing that, then it becomes a muscle memory. Once everything comes as a muscle memory, then you become speed or fast surgeon. Never aim for becoming a fast surgeon. That would be my advice to all the young people.
Absolutely. Um, the today's young surgeon face unprecedented pressure, speed, visibility, social validation, and commercial influencers. I'm sure that's what you really, meant it very well, because the constant culture of comparison and the instant result mindset, definitely it's not going to help. The ethical challenges are going to really cause the challenges. It will have uncertainty, and there will not be any kind of an area of expertise which will help them for a better result. Doctor, how do you mentor emerging surgeon to balance efficiency, precision, and compassion in high pressure clinical environment?
So I just talked about precision and speed. So I would say that always precision first, speed will come. It is a byproduct. And then compassion has to, uh, the problem is, there are certain qualities which cannot be cultivated or can be cultivated, but only with great effort. So rather than having a competitive exam where the, people with the best knowledge enter the MBBS or medicine, you know, we want to have a character exam where only compassionate people are
Wow.
allowed to enter medicine. This will take medicine to a different level where, when you if all the people who are in the medical field, if they are compassionate, you will feel as if you have returned to your mother. When you are in hospital, everybody will be taking care of you as a mother would take. So though there are ways of developing compassion, but for that the guru is required. you know so the in Sanatan there are a lot of ways where bhakti will develop compassion. So but I don't think anybody will take this path of bhakti. Once you have compassion towards fellow being, then that fellow being is going to put his faith in you. And I think it is extremely great privilege as a medical doctor that anybody comes to you and gives his well-being in your care. That is, and that responsibility weighs very heavily on us, and we see to it that we stand and we respect that. We take great care. We will not utter a single word which will harm the patient. We will not uh, take a single step which will harm the patient.
Absolutely. I must emphasize that efficiency should never come to the cost of judgment or humanity. Rightly
Mhm.
said.
Yes.
And the precision which is learned through a discipline, and the compassion through awareness. Of course, I also encourage the young surgeon to slow down, whatever is needed, think, contemplate, reflect, and remember that every patient you encounter is a human interaction, not a task to be completed. And very well said, doctor. Definitely the balance will really develop them with the self-awareness and the guided experience, as you mentioned. Now, moving on to the 11th question. In your view, what truly differences a technically excellent surgeon from one who is patient centric and ethically grounded?
Uh, so when a surgeon thinks about a procedure and thinks about a flawless procedure, so that is what a technically superior person is. He has mastered materials, surgical environment, and sometimes himself also. So to give a flawless surgical end result, but still you have to think about how to optimize the patient. And that optimizing the patient comes only when you get involved with the patient, when you understand the patient and you put the patient at ease. Once the patient is at ease, then the patient's stress levels falls, and you operating on a patient who is under stress is never going to give you optimum results. More so when the patient is in an advanced stage. Stress does lot of things. Stress creates lot of diseases, and stress can harm the physiology of the person. So therefore, a technically superior or technically fine surgery can still have other complications. Why? Because patient is under stress. Patient's tachycardia is not settling because patient, when he went under anesthesia, he did not have faith in the system. That is why patient's tachycardia is persisting. And when such a thing happens, slowly patient keeps on gathering the stress and he's unsure whether everything is happening correct. See, everybody might tell him that okay, everything is okay, but that he has to feel it from inside. You know, so that comes only with faith. So lot of time has to be spent in creating that rapport between surgeon and the patient. If it is not happening, some other surgeon can develop that. You may not be that surgeon who can develop that.
I really echo this example. When I moved to medical product and medical device industry, worked with the number of healthcare professionals and handled many hospitals across India and pan India. I must say that couple of hospitals, when you really entered, you get the feel of, oh wow, it's
Mm.
not, it's really feel that, they are being so compassionate, they've been so kind. So I must say the difference lies in accountability, humility, ethical clarity, or the willingness to prioritize the patient welfare over your personal ambitions or the external validation.
Mm.
That's what something really matters a lot. So, doctor, I would like to ask, when it comes to there are different scenarios you might have encountered, and you might have to understand that no, this is the right decision. And had it been ever possible that you have taken a decision out of your will, and not thinking about the particular institute or any time?
No, I didn't get you.
I mean to say that, have you ever come across with the scenario where
Mhm.
when not operating is the right decision? And
Oh, that way.
yes, yeah.
So, so actually, definition of surgeon,
Yes,
definition of surgeon or experienced surgeon is when he knows when not to operate,
yes.
because see, surgery comes, that is what we have been taught. Surgeons are taught surgery,
Mhm.
but with experience, experience teaches us, okay, this is not a surgical problem, this is other way, or this is a character problem, or this is a behavioral problem, or this is a medical problem. This can be solved with tablets, or this can be solved with psychotherapy, or this can be solved with maybe personality development, or this can be solved with gait training, this can be solved with voice training. So there are so many other things that are already there, and surgery is not the only solution. And actually, we have to see to it that we look at surgery as a last resort. A surgeon has to always think about surgery as a last resort. He has to always, think of making the patient better without surgery. That, if it that is not going, it's not happening, or multiple good doctors have tried it already, and still the problem persists, then he would think about surgery as a last resort. And then, in such a scenario, he has to tell the patient that, okay, we are going ahead with this because there are these problems, and then these many complications are possible. But we have to do with these complications, we have to take this risk because there is no other way. Surgery is the only way. And then there are certain cases where surgery is the least damaging way. You know, in case of most of the times, cancer or tumors, where excising a tumor is going to harm only a part of this body, or rather, others, when you take a medicine, or whether you go for chemotherapy or whether you go for radiotherapy, large part of the body is now damaged, and that damage is going to remain with you for rest of the life, or sometimes keep on getting severe. you know the surgical problem or damage that surgery has caused is going to become less and less, and it is going to improve with time. So these there are these scenarios also. So the surgeon only with experience understands that when surgery is the primary choice or surgery is the last choice.
Absolutely, absolutely. I think that is something which can really help, because one of the hardest decision, I must say, that when it comes to the ethical integrity, understanding all the aspects, and you really feel that yes, this is the gut feeling which is really saying that what has to be done and how it has to be rectified. Amazing, amazing. And now there we will be taking couple of questions from the chat, or we have received from the couple of other forum, the social media also. So, doctor, there is one question from the other person, who is saying that how do you navigate the situation where commercial or institutional pressure conflict what you must have encountered with for the best of your patients too.
Uh, yeah, so sometimes the there are certain administrative personnel who will come and talk to you and will try to guide the treatment in certain way, you know. So this becomes a very tricky situation, where actually now what happens is that surgeon is working with the hospital. Okay. And this is a now a long relationship, which is going to be for many, many years. And now administrators want treatment in such a way where now surgeon is on the side of the patient and is trying to antagonize sometimes. He might have to antagonize even the administrators because he is always on the part of the patient, you know. So he cannot be any other way. There is no way that we can be on anybody else's side. We will always be on the patient side, and sometimes we have to antagonize administration. There is no other way. And if administration does not understand, then maybe I think the relationship is not going to last long.
Yeah, absolutely.
Hmm.
It really matters a lot that when we treat a different cases, and we really have to handle differently also. So there are a couple of other more questions. It is coming from the other social media to us, that how do you define that the plastic surgeries, which is a trend in nowadays, is it really good for the new generation, or is there any age group has been involved?
So yes, lot of patients come to us and ask us whether should my child undergo plastic surgery. So I ask them, does he take bath? Yes. Does he brush his teeth? Yes. Does he comb his hair? Yes. Does he wear iron clothes? Yes. Does he polish his shoes? Yes. And aren't these external things? Huh? This is not going to change his body. You are going to have different clothes every year, but his body is going to be with him for many, many decades. Now, if you are going to take care of your external things in such a way, and then you don't want to take care of your body, it's absolutely personal question. See, we cannot judge what matters to person and to what degree. So that is why for aesthetic cases, it is worthwhile to sit with your surgeon for at least three sittings. Three proper counseling sessions are must, so that surgeon can get into the patient's head to understand, what are his spiritual beliefs, what are his professional beliefs, what are his requirements, what is his routine, how he feels that the aesthetic procedure is going to change his life or whether it is not going to change his life you know so all that things, it takes time for the surgeon to enter the patient's mind, and that also patient should allow. After that, then surgeon has to talk to the patient, telling him that, okay, even if you want this, these are my limitations or these are procedural limitations. you know Only the nose can be changed only to certain extent. Beyond that, if you try to go, then you will have functional problems. The airway will not be adequate and you may have oral breathing. So narrowing can be done only up to certain extent. If uh, more narrowing is done, then the nasal airway is not going to be adequate. So those problems have to be talked out, and only with proper patient counseling, these things can be resolved.
Absolutely, absolutely. I strongly believe that the patient autonomy always comes first, and there should not be any. When we say, in India, the 18 years of age, which is an age group. Okay, so I must say that they have a full right to understand for themselves, and to make sure that they should not be forced, not with any kind of a critical influences too. There are a couple of other questions that, if you had to explain to a non-medical audience that what ethics in surgery really means in one or two sentences, how would you frame it?
That's a tough one. But you know what I will say? Ethics means well-being of the other person. That is what is ethics. So when you are thinking about patient's well-being, everything is ethical. There's nothing else. You know, it, patient's well-being in short term, medium term, and long term, all the way.
Absolutely, absolutely, very well said. So from Tejaswani AP, we have the question: how should younger surgeon think about balancing what the book says with what experience teaches?
Hmm. Mm. See, you have to always understand that book is written by a person. Okay, so in the end, it is not Vedas. That it is not that somebody has given this. This is an experience of a person, and it's a personal experience. So as the surgeon starts maturing, he understands. He starts reading between the lines. So if he does not understand what the book says, the best way to understand what book says is to visit the person and understand what his patients are. So uh, I started doing microvascular flaps on the thigh. So there is certain way those flaps are marked and one artery is found out. Now, when I used to do this, I used to find that no, that artery does not sit there. It is about an inch or sometimes 1.5 inch medial or little away from the point that is given by the marking, which is from the Taiwanese surgeon. So then I went to Taiwan. And when I saw, then I realized why this difference occurs. Because if the Indian thigh is, let us say, of size of a uh, maybe a tablet, hmm, how much the tablet is, and the Taiwanese thigh is twice the size of Indian thigh. Because of that, now the markings are different on Taiwanese thigh and markings are different on Indian thigh. So that is how you have to understand. See, both are correct. Your experience is also correct, and what book says is also correct. But the circumstances under which it is correct is different. So those circumstances, how they are different, you have to understand by going to the source.
Absolutely, very well said. I'm sure the experience will teach you the better to be think through that. Of course, the book has really mentioned the certain criterias with an examples or the set guidelines or the used case studies. However, your experience will teach you to be a better person. Now, there is one more question would be from my end, doctor. At this stage of your career, how do you define your legacy as a surgeon?
Mm, my legacy. Oh, I don't know whether I would want to live legacy as a, or maybe I have already left a legacy. So when I started in Tata Memorial, that time microvascular surgeries were not that often. And the microvascular surgeries were only being done in corporate hospitals because it required a lot of setup, etc. So when I left the Tata hospital, then I started doing microvascular surgery even in nursing. So then everybody started developing confidence that okay, the nursing home also can uh, cater microvascular surgeries to patients. It can be managed and not intensive monitoring is not required. Everything could be simplified. So maybe I think that would be my legacy, or maybe leaving a legacy is not a good thing.
You've been so humble, and it's really grateful to hear about your experiences. I must say that legacy is not just a number of surgeries what might have performed, but it is a number of lives lived positively and which is impacted, and the professional who are mentored, and ethical standard which is upheld. So it's really grateful honor to have you, Dr. Charudatta Chaudhary. And beyond techniques and the technology and the surgery, which is an ultimate act of a trust, today we have learned an amazing aspects of the beyond procedures, ethic, experiences, and the patient-centric outcomes in surgery. I must say that as a surgeon, as a healthcare professionals, the greatest responsibility is not just to operate well, but to decide wisely, communicate honestly, and care deeply. Where ethics guide the decision and the empathy which shapes our actions, outcome extend beyond the operating room into a life which is restored, confidence that is rebuilt, and the humanity which is preserved. That's something, Dr. Charudatta Chaudhary, a true purpose of modern surgery, which you have shown us today. It's a really humble gratitude and grateful. Thank you so much for being with us today with the JVA Tech Motivations and the Power of Knowing You Forum and Collaborative Health Tech Podcast Series, Episode 2. Thank you so much, Dr. Charudatta Chaudhary.
I thank JVA Tech for having such a fun session, because we always talk about surgery and we don't talk about philosophy, because as we start experiencing, we start developing certain philosophy which is maybe unique to each person. And I think that is what you got out of me. Thank you for conducting such a good session. Thank you.
Thank you so much for always being there with us. Thank you. Yeah.
Thank you. I'll take your leave. Thank you.